Hi, this is Wendy, and today we're going to talk about OT in acute care. There's three types of situations that you might care for a patient. They are acute medical conditions, this would be things like if they had a stroke, a heart attack, they might have a sudden onset of respiratory failure, undiagnosed diabetes, various types of infections, UTIs, bone infections. They may have fractures from falling. They may have a TBI. There's many more, but that's some of the common conditions that you would see that are acute. You also have post-surgical. Post-surgical might be your joint replacements. Someone may have fallen and broken their spine and need to have a kyphoplasty. They may have had appendicitis and bowel obstructions. Again, there's many more. Those are the common ones. And then we have chronic medical conditions. So these would be things like chronic medical conditions that have had an exacerbation of symptoms. So they may have worsening heart failure or worsening respiratory conditions. When I did my field work at the acute care hospital, we saw a lot of heart failure and respiratory conditions. Those can deteriorate really fast and require a much higher level of care. OT's role in acute care is we would evaluate the person's current abilities. This begins with a review of their medical records. This is very important. You need to know not only what they're in for at this time, but their past medical history could be a key factor in their recovery, in their ability to complete their self-care. It's important to also talk to nursing. You may read something in the chart and it might look like they're pretty stable, and you go to the room an hour later and they could have a major decline. So it's always important to talk to nursing before you go into a patient's room. Read any precautions. Most hospitals that would be listed on the door, the precautions such as if you need to wear a mask or a gown or gloves. Typically you would wear gloves for everybody, but you may not need a mask or a gown unless they have some sort of condition. It protects you from contracting anything from them, but it also prevents them from contracting anything from you. People with a weakened immune system due to these medical conditions could get sick very quickly from something like a common cold that you or I may have. Sometimes you have to have a face shield as well. You also want to be aware of any precautions such as weight bearing, sternal precautions, spinal precautions. It's not always easy to see that in the record, so sometimes you have to dig a little bit deeper, maybe look at physical therapies notes to see what their precautions are. The hospital that I was at, many times it would say weight bearing is tolerated, and then when we went to look at the PT record, it actually showed that they were non-weight bearing. So you want to check and double check. It's better to err on the side of caution and use lower weight bearing. So it's better to tell them that they're non-weight bearing than to tell them that they're full weight bearing. So that's very important. Then of course we want to remember to keep it all client centered. So once we look that up, we're going to go into the patient's room and we're going to figure out what their living situation is. Who do they live with? What type of house? How many stairs do they have to get into the house? Is their bedroom upstairs? If their bedroom's upstairs, that poses a big problem for most people going home from an acute care setting. What equipment do they have at home? So we would also ask them if they have a shower chair, a walker. They may never have used a walker but may need one. Do they have a bedside commode? Do they have, if they've had a hip surgery, do they have a reacher? Do they have a sock aid? Do they need it? Do they wear socks? Do they wear sandals all the time? Basically, you want to look at all the questions that would help determine their level of independence upon going home. And then we want to ask their prior level of function. You're going to write goals differently for somebody who needed assistance to get to the bathroom before they got sick and came to the hospital versus somebody who used to be out running 10 miles every day and had some sudden heart condition, and now he's having difficulty just walking to the bathroom. And the easiest way in acute care to evaluate a patient is to work on self-care. So if they've been in the emergency room and they just got into their room a few hours earlier, or they just had surgery, more than likely they have to go to the bathroom. The nurses love to give them a bedside commode or something to make it easy. But now we can evaluate them to walking into the bathroom. If they could do that before, can they do that now? Brushing teeth. When I offered to have people get up and brush their teeth, they thought that was the best thing in the world because it makes you feel so much better to brush your teeth, brush your hair, wash your face, and we can assess a lot about their mobility, their transfers, their static, dynamic sitting balance, as well as their static and dynamic standing balance, and their level of independence with ADLs. Can they stand at the sink? Do they need to sit at the sink? Would they be able to do that again when they go home? All of this information will help us to work on the discharge planning. That has to be done right at the initial evaluation. At least you have to have a plan for what the patient would benefit from. Can they go home? Should they go to acute rehab, which is a lot of therapy a day? Can they tolerate that? It's about 3 hours a day. Would they go to a skilled nursing, long-term care, etc.? We can change this, but we want to have a good idea from the very beginning on where we think their best placement would be. And then we have the treatment plan. And if there's CODAs working, then the treatment plan will help them determine which goals that they'll work on while the patient is there. Acute care is generally a short stay. You could evaluate someone today and they could be discharged tomorrow. So you want to keep that in mind. And we want to reduce the risk of further decline. Improve their functional independence. And then again, assist with discharge planning. The last thing we're going to talk about in acute care is the goals. The goals are short term. We do write long-term goals, but they're not going to be for 3 or 6 months. They might be for a week or two. So a short-term goal might actually just be for a couple of days. So you're not looking at a large improvement. So if they're max assist for a toilet transfer, you might write a goal for a short-term goal for mod assist for a toilet transfer. And a long-term goal might be min assist for a toilet transfer if they were able to do that before. And sometimes the goals need to be adjusted. So if I evaluated a patient on a regular floor, maybe with a respiratory distress, and then they go to ICU, they may be intubated. When they are extubated, then we need to evaluate them again. More than likely their functional status has changed. They're probably a little bit lower if they've been intubated for several days. And when you're writing goals, you're really looking at functional mobility, basic ADLs, bed mobility, range of motion, and some education on energy conservation and work simplification. So we'll do mobility, ADLs, bed mobility, range of motion, etc., based on the needs of that patient. Thank you.